great welcome to this session. Just to briefly introduce ourselves, my name's James Seddon. I work at Imperial College in London. And
so I'm not Courtney Yuen, I'm Pete Dodd. Courtney couldn't make it, and I'm at the University of Sheffield in the UK.
So we have a very exciting session. We've got 5 speakers, and the plan for this, when we put it together, Pete and I kind of thought a bit about this. We wanted to really bring the concept of how you use numbers to really inform paediatric TB. And we've got a really wide variety of different speakers who are talking about very different ways that they've used numbers to better understand paediatric TB. And so they're quite different disciplines, but we really hope they'll come together to give us a good idea of how we can use these ways better. So with no further ado, I'm going to invite Helen to come and give her talk. Helen works at the University of Boston. I'm going to be ruthlessly mean with timing. So at 12 minutes, I'll start waving, and then we'll throw you off the podium maybe a minute later.
Great. Somebody going to catch me, hopefully. So thanks very much, James, and thanks for the invitation to speak. I'm going to be talking today about a couple of pieces of work that we've done on childhood TB case fatality ratios and the implications of those for mortality estimates. So just to make sure we're all up to speed on the latest numbers, almost all countries now do report age disaggregated notifications, so that's great. And the latest WHO global report reported that there were 1 million new cases of TB disease in children in 2015. So in last year's global report were the first WHO estimates for childhood deaths due to TB, and they estimated those to be about 140,000. And for various reasons with improved data, this year that number went up to 210,000. So that's in children under 15. It's not age disaggregated. So how do they calculate those numbers? Well, those are based on vital registration data, and you can see on this map, all the countries in red are the countries that do report vital registration data. And then the WHO use an imputation method to calculate those numbers for the countries which are in white. And there are various kind of well-documented issues with vital registration data that I don't have time to go through today. But we said maybe we can look at this question of how many children die due to TB in another way and look at it from the other side. Instead of going through death records, can we say, well, we know 1 million children get TB each year. What's the chance that they're going to die? And can we calculate these percentages that die and then estimate how many actual children are dying? So the first step of that was to do a systematic review of mortality in children with TB. And so we searched the literature for studies that looked at children with active TB and then ideally followed them and identified how many of them died within a year of diagnosis. So we used various search terms. We excluded various studies that we felt might bias our estimates. And of course, we can't just say that every single child who gets TB has an equal risk of death. So we wanted to try and stratify our estimates in some way. So the first thing that we thought would be important, unsurprisingly, is whether or not children actually receive treatment. So we think at the moment that about 2/3 of children with TB aren't being diagnosed and not being treated. So this was really important to understand what happens to children that don't get treatment. Obviously, it would be entirely unethical nowadays to do a study of children with TB and not treat them. So we felt the only way to try and look at this problem was to go back to the pre-treatment literature. So we went through studies pre-1946. It's actually surprisingly hard to actually search for those and find them, so that's where we used the encyclopedic knowledge of Peter Donald and Ben Murray to identify a lot of those papers for us. As a side point, if anybody here has not gone back and looked at papers from the 1920s and 1930s, it's a really fascinating thing to do. I highly recommend it. So then the next thing we were interested in looking at was trying to stratify by HIV status. Again, we kind of hypothesized that children who were HIV co-infected would probably have a higher risk of death. So we were hoping that we might be able to find studies that stratified in that way. And we were also very interested in looking at stratifying by age. So again, we're hoping to find studies where they actually broke down the numbers into those age groups. So I've got my 12 minutes. So the bottom line on this slide really is that we identified 35 different data sets to include in our analysis. So this picture is showing you all the different studies that we found. So down here, we have all the different studies and the locations of those studies. As you can see, the majority were from the Americas or from the European region. And across the bottom, we have time. So the shaded bars are showing you the time period during which each study was conducted. So you can see we had studies ranging from starting in around 1920 all the way up to finishing just a couple of years ago, a whole range of studies. And to get at this question of whether or not children receive treatment or not, we decided to break our studies down into 3 different groups. So the red ones are those pre-treatment studies, so before the development of streptomycin, where we could be sure that children had not received antibiotics. The blue, the middle era studies, are those ones where some children would have received some treatment, but not really regimens that we are using nowadays. And then the green studies are those from what we call the recent era. So there, that's after the expansion of DOTS, we are able to assume that all or virtually all of the children in those studies received treatment, and they received the types of regimens that we're familiar with now. So from all of our studies, we had over 80,000 children diagnosed with TB and just over 9,000 who died. So the pre-treatment era studies, we estimated that around 22% of children under 15 died in those studies. And as you might expect, for children under 5, that was much higher. That was about 44% of children, and then about 15% for those aged 5 to 14. If we skip down to those recent era studies where almost all children received treatment, as you would expect, the number is much, much lower. Only about 1% of children died there, slightly higher for the under 5s, around 2%. So we were very pleased. We had a decent number of studies of children who didn't receive treatment. We were able to estimate those fairly well. And we were also really pleased that we were able to stratify by age. The data we had on HIV was a bit more disappointing. We did have a large data set from the United States. So they stratified children depending on whether or not they were HIV co-infected. And it covered about 20 years. So we were also able to divide the time period up into 2 chunks of pre the widespread availability of ART and post. So we were able to get some kind of handle, at least on the additional risk of HIV co-infected children not receiving ART. I don't have the specific numbers on here, but as you would expect, case fatality ratios were higher for children with HIV, and amongst those children, they were much higher before the widespread use of ART. We found one study from a high HIV prevalence country, which was this study from Mozambique, but they didn't stratify by HIV status. However, more than 10% of those children died, so much higher than you saw in the recent era studies where it was about 1%. HIV prevalence in the entire cohort was about 72%, but that included adults, so we don't know specifically what it was in children. But this is obviously very concerning, although it may be due to other factors, not just HIV. So the next part, apologies for the very busy slide, but the next part of the project is to take these case fatality ratios and actually apply them to the numbers of incident pediatric TB cases. So we take our 1 million children who get active TB each year, and first of all, we divide them into how many we think receive treatment and how many don't. So here we make this assumption that those notified to the WHO are those receiving treatment, those not notified are those that are not receiving treatment. So there could be potential problems with this. Yes, there could be children who are not being notified and are maybe being treated in the private sector. So we're currently doing some sensitivity analyses on this. We then use UNAIDS country HIV and ART prevalence data and data from a systematic review that Pete did, looking at incidence rate ratios for TB for people with and without HIV. To be able to split these then into those that we think are HIV positive and those which are HIV negative. Then we apply our case fatality ratios to estimate how many of those children actually die in each of these groups. So again, we have to make various assumptions. For example, we're making the strong assumption that those data from our pre-treatment studies are actually applicable to 21st century situations, particularly in Africa and Asia, where lots of children are not being treated. We also had to make assumptions about, this group which are untreated for TB and are HIV positive. Obviously, we had no data on those, so we're having to make some assumptions here. So these are very preliminary results. We're in the process of updating them. The bottom line is that we estimated that around 218,000 children die each year due to TB. In this bar, you can see how that breaks down by region. So as you would expect, the kind of largest share of those is due to children in Southeast Asia, which I think is unsurprising, given that's where India is. And then the second largest group is those in Africa. Then if we look at this bar, this is breaking down children into those groups that you saw on the previous slide. So this kind of very small blue bit at the bottom here is the contribution made by children who are receiving TB treatment. So that's obviously a very small contribution. Then we have these two other small ones, which are the contributions of children who are HIV positive. Then the vast majority of children dying each year, we believe, are untreated children, so untreated for TB and HIV negative. And the majority of those are then children under 5. So as you can see here, untreated children make up 98% of the total mortality, and children under 5 make up about 83%. So I think the really important message here is that we need to be finding these young children and getting them onto treatment. But I think the most important slide from this talk, this is why I wanted to go quick, because I didn't want to be wrestled off the stage before I got to this one, is this slide. So this is the most recent paper about under 5, so causes of mortality in children under 5. And if you search in this paper for tuberculosis, you will not find it anywhere. There's no mention at all of TB. And this table here shows you the top 9 causes of under 5 mortality in children under 5 and over 1 month of age. And we believe, so these numbers are in millions, we believe that TB should be coming in here around number 6. So I really think that the main message from all of this work is that TB is a really important cause of under 5 mortality and needs to be taken a lot more seriously. Finally, I'd just like to thank all my fellow authors on these 2 pieces of work, and thank you for listening.
Thank you very much, Helen. Awesome timekeeping. Very, very good. We have time for a few questions, if there are any from the floor. Anna, can we have them on the microphone, because they are recording the session?
Hi, Anna from MRCCTU. I'm pediatrician. Nice. Helen, very nice talk. I just wanted to clarify, you were talking about HIV, TB mortality. Did you look in the cohort of TB patients who were diagnosed with HIV and died? Because there is quite a lot of information with, from the cohort of HIV patients from developing countries and, from north, like US cohort, our CHIPS, United Kingdom cohort. When we looked prospectively in HIV-infected children, and then saw, how many of them dying with TB.
I mean, so we had to do a systematic review, and we couldn't kind of trawl through every single thing that possible. So we did our review very, very systematically, and these were the papers that came up. And there were a couple of others that I haven't shown that had very small numbers, but these were the papers that came through. And we'd have to talk afterwards to find out why those ones didn't come through in our review.
But that's a different group of patients, actually. Those are a group of patients who were picked up in the systematic review that Pete and I did to look at the impact of HIV on children with TB, which then fed in further down in the second model to determine what the risk, if you've got TB and you've got HIV, of dying is. So that all those studies, I think many of the studies you're talking about would have fed into that systematic review. Yeah.
Yeah, Jotam Paspanologica, physician from Zimbabwe. Did you look at M. bovis?
No, we didn't. So that did come up in there was one study from many decades ago where M. bovis did appear, but the numbers were very small in that particular study.
But especially for...
Sorry, yeah. Keep going.
Yeah, but for the ancient era, the M. bovis would have been...
Oh, I'm sorry. Yes. So we didn't... Maybe that they, in some of those studies, they didn't specify the difference between M. bovis and M. tuberculosis. I'm not sure, but I don't remember seeing any particularly coming through.
Okay, 2 more questions. One.
Hi, Helen. Catherine Snow from University of Melbourne in Australia. I suspect that you're much better placed than me to understand the GBD methodology, which I'm consistently baffled by.
I might be joining you in that.
Yeah, okay. What do you think explains the discrepancy between your results and theirs, though? Why do you think that they miss TB when you put it so high in that top 10 list?
I honestly don't know. I don't know if Pete or James may have some better ideas on this. I find it completely frustrating that it's not appearing in that list, and I wish it would. I think I'm hoping that we can publish these results and we can actually kind of change the conversation really around this.
I think part of it is that the kind of shared list of child mortality causes explicitly exclude case fatality-based approaches to generating them, so they want to base it on vital registration data. And I think one of the next steps for us is trying to find a middle ground that is acceptable to them given those terms, but actually doesn't go badly wrong.
But we now got the WHO making estimates which are vital registration based, which are triangulating very, very well from the case fatality rate. So I think that provides quite a strong motivation for saying this is is a reasonably legitimate way of getting. Final question from Sylvia. Okay, we should probably move on then. Thank you very much, Helen. Can I just quickly, is Anna Mandalikas here? Is Anna here? Does anyone know if she's around, and does anyone have any contact? Okay, she might come in late, so we might have to juggle the order potentially. Do you want to introduce Radha or something? No, okay, so the next speaker is Radha Savage, who's coming in, and you're at San Francisco, aren't you, Radha? And she's going to tell us about modelling approaches to be used in the field of pharmacokinetics.
Yeah, well, good morning, everybody, and thank you for staying until Saturday to listen to us. Well, here I'm really standing on behalf of TBM Kids clinical trial, which is a first clinical trial in pediatric TB meningitis in 70s. And there's been a lot of number-related work since this session about the numbers that went into design of this trial and just making sure the trial actually pans out in a good way and we have a better treatment strategies for TB meningitis in children. So I think after my previous talk, I don't need this slide, so I think we are really covered. But I think we can really, if we dwell a little bit on the what does pediatric TB look like and really what kind of disease risk representation are there, we can see that in children less than 1 year old, we have quite a lot of TB meningitis. So 10 to 20% of TB meningitis, which is not that present in older age groups. TB meningitis is in adult population mortality is very high, 50%. In children, young children are the most susceptible. However, mortality is not that high in children, is around 10%. However, morbidities, which I will just show you in a moment, are really devastating. So kids are fairly able to survive, but then what they really the way how they pan out after that, it's really worrying. One of the concern, I'm bringing here Indian dosing recommendation because our trial is really has a couple of sites in India, but in India we also still are using intermittent direct observed therapy even for treatment of TB meningitis. Really the problem here is that the dosing that we're using is not guided by any clinical trials. And if we think about the drug for TB meningitis, rifampin, which is really a key sterilizing drug, has to reach the brain, has to reach cerebrospinal fluid, has to cross the blood-brain barrier, should not be PGP substrate, and so on. So there's all these requirements for the drug actually just to get into the brain and to exhibit its mode of action. And we're assuming that actually is going to be the same for TB meningitis as for other form of TB by administering the same treatment of TB to children. So as I mentioned earlier, data are sparse on really what TB meningitis does to kids, but these are some of the data that are out there, and we can see that in the stage 2 and 3 of TB meningitis, after 6 months of the treatment, around 60% had IQ deficit of 50 to 80, and really children really do get impaired for the rest of their life with these severe morbidities and really impairment of their intellectual abilities. And their ability to thrive is minimized. So I think that's really devastating if you have a very little child that might survive but then be impaired for lifetime. So So just to remind you about the drugs, so WHO recommends currently 2 months of HRZE followed by 10 months of HR, and we are using the same rifampin doses as for any of other form of TB in children, which is between 10 and 20 mg per kg. And please note, this is not standard of care in many settings. This is standard of care in South Africa, but not in other countries. As I said, in India, we're still using thrice weekly. One thing that you can notice is for rifampin, that this ratio between plasma and cerebrospinal fluid is very low. It's between 0.04 and 0.11. And this really means that only around 10% of the drug actually crosses towards the brain. So we are really effectively giving 10% of the actual dose to treat TB meningitis in children if you want to be equivalent. So fortunately, there were trials in adults. And this is one of the trials that was run in Indonesia where they actually looked in 2 different doses, 450 milligram oral versus 600 milligram IV. And this trial was kind of small. It was not powered for efficacy, but they really seen that mortality was substantially, significantly decreased with high dose of intravenous rifampin. So really, I think this is no-brainer. By increasing rifampin dose, we do get better outcomes, and this has been shown in every type of TB in adults and children. I think that is really the direction to go. On the other hand, we also had another trial which was run in Vietnam, where they also tried to intensify TB therapy in adults with TB meningitis, and this is a trial that just came out in New England Journal of Medicine, and in this particular trial, there was really no difference between control arm and increased rifampin dose arm. You can see that mortality in the middle column is 28% with control arm dose and also 28% with experimental arm dose, and experimental arm dose is just upped, I think, 50 to 20 mg per kg. And, it's 50 mg per kg rifampin. And also we are learning from the TB pulmonary trials that increasing the dose up to 50 milligram per kg is probably not enough to actually have certain better outcomes. So now we have these couple of trials in adults, and we want to have better regimen for children. And really, how do we think about that to actually to design trial in children and to make sure that they're getting the adequate doses? So this is a guidance from FDA for any type of pediatric trial. So they really say, we do use this equivalence approach where we say we can assume the disease is the same in adults and children. And if that is the case, then the only thing we have to do is really we have to approximate the doses in children, which would give us exposures in adults. So basically, we have to figure out how to dose the children to reach the same exposures, and then we would really reach the same efficacy. I don't think I want to go into that discussion if the TB meningitis is the same in children and adults, and it's also for other form of disease. But I think this is the best we can do, and at least we can aim to achieve the adult targets. So how do we do that? This is where really numbers are coming and modeling approaches are coming. But one of the first things we would like to do is we would really like to understand this relationship, how PK predictor in adults relates to survival, and this is really the type of quantification that you would like to have. And then when we derive this type of the model, we can actually derive the target that will give us the best possible survival with this drug at this PK stage. And then once we know this target, then we can go into the pediatric population and we can ask the question, how shall we treat the children of all ages and all weights in order to achieve that adult target? And this is what we've exactly done. We've had the data from that adult TBM trial in Indonesia that actually showed efficacy. And so from this data, we got a lot of PK samples from plasma, from CSF. We got clearly survival data. And as a first step, we've built these models, but actually really the idea with the model is to understand how the drug goes from the absorption site to plasma, but most importantly, how is it crossing to cerebrospinal fluid, and what is the ratio of the drug in cerebrospinal fluid. Once we know what is the drug in cerebrospinal fluid and in plasma, we can ask the question how the concentration of this drug relates to survival. So this is really just the first step to understand how this looks like. So in the second step, as I said, we can then relate the PK measurement from plasma or from CSF to the survival. And then, this relationship looks very steep. And then from this type of relationship, we can ask the question, how high we have to be in order to get the maximal benefit. And in this particular case, we defined that we have to be at least above 92 milligram, AUC of 92 milligram times hour per liter in order to have 99% maximum response, which would be increase in survival around 40%. So now, once we define this target, we can go back. But now the question is, we can have this target, but really thinking about children and how to dose children optimally, and every single child to get this target is actually quite complicated, because children really is moving target. There's a lot of things going on. They're changing. The liver is increasing. The maturation processes are changing over time. So really, there's a lot of things that we have to think about. The other thing for rifampin that we don't really know well about children, but we have all this induction thing going on. Once you start treating rifampin, it induces all enzymes in the body, including itself. And what that really means for the exposure, it means that exposure is decreasing over time. So we start with very high exposures, but then the entire enzyme system is induced, and then the rifampin goes down. And that's something we have to think about, because we really want to make sure that we get enough rifampin. And then the third thing, which is really, I think, very complex, and often we don't factor this in, but this is just an example of our typical pediatric population in India. And this is a growth chart according to WHO, weight versus age. And you can see where our children are. They're severely malnourished. Most of them. We have around 40% of the kids. So all of the kids are below the 50th percentile, and 40% of them are severely malnourished. So we have a kids 12 years old that actually weigh around 12, 13 kilos. So that malnourishment is also something we have to factor in when we think about these dosing charts. So now that we have this target and thinking about all of these things in context of these models, we can now ask the question, how shall we dose these children to reach these targets? And you can see it's hard. So basically, these are different age groups. If we didn't give 10 milligram per kg, nobody will reach the target. If you give 15, WHO dosing guidance is, again, we improve a little bit and so on. So really, with 30 mg per kg, we're still not there. So it seems that we have to go as high as 60 mg per kg to actually start even being equivalent to adult exposures in children of all ages, once we factor for all of these factors that I just mentioned to you. So really, we have to settle on something for the trial, because clearly we can't just increase the doses 6 times. But this is a proposal that went into TBM Kids clinical trial, and we've settled with to use either 30 mg kg orally or 50 mg kg IV if we could, because IV is much better mode of action in order to increase exposures at least 3 times compared to what has been seen before. So then we also have levofloxacin, and I haven't shown trials, but there has been some trials suggesting that upping levofloxacin can actually benefit TB meningitis in adults. And then we use the same approach. So we actually went and looked into the children data, developed the models, and then we asked the question, what are the oral doses of levofloxacin required to reach a plasma AUC goal of 101? This is the adult target for children. And you can see that we actually had to up levofloxacin sometimes up to 30 mg per kg. Than what is currently given, 10 to 15 mg per kg. So these are some data from Annike Hessling.
1 minute.
I'm finishing. Where she actually showed that increasing levofloxacin to 50 mg per kg does not have any QT concerns, and that is where we settled at 15 mg per kg for our trials. Again, we have to do it stepwise. So, and this is really where we are now. We have a first clinical trial, pediatric clinical trial on TB meningitis. We have 3 arms. Both arms have very high doses of rifampin, and one arm has levofloxacin, the other one doesn't have. And we actually, I think, about to enroll a first patient these days, right, Kelly? Yeah. Yeah, Kelly is really hopeful. So acknowledgements, really Kelly Dooley, who is a PI on TBM Kids. And there's a lot of collaborations from all around the world, from India, from Netherlands, from South Africa, that all people that share their data to help us understand in order to figure out these doses in the best possible way. Thank you.
Great, we've probably got time for one question if someone's got a burning question. coming. So I'd ask a kind of slightly contentious question. What would be your perfect dose if you didn't have to worry about side effects or national programs pushing back? What would you be giving children of different ages rifampicin to treat TB meningitis?
I would go with, if there's no clearly safety concerns, between 40 and 60 mg per kg, but I'll probably divide in twice a day.
Okay.
IV and hopefully IV, yeah.
That would be...
Yeah. I said it would be 40 to 60 mg per kg, but that would be oral. IV, it could be less, it could be half of that, 20 to 30, and if possible, BID by IV route. Because then you really get high Cmax, you get that force into CSF, and you don't have like a period of times during the day without the drug, because rifampin is out by 12 hours. So basically, you have a half of a day that you don't have any drug. So you really want to kind of keep the drug coming in.
So 30 milligrams per kilogram, twice a day, oral.
Oral, yeah.
Very good.
Yeah.
Okay, thank you very much. Okay, so we're going to slightly change the order. Anna had actually told me, and I completely forgot that she was going to be another session. She could come at the end. So if we can move on now to Massini, is that okay? So if we can have Massini Carafu's presentation. So Massini works in Imperial with me and is going to tell you about how we can use data in a different way to think about biomarkers and TB diagnostics.
So, hello everyone, it's a pleasure to be here and thanks for inviting me. I'm going to talk to you today about host biosignatures for TB diagnosis and the analytical challenges we face and where we hope to take this field in the future. So there is no need to describe in a room like in an audience like this one that we don't have the perfect diagnostic test for TB yet. And although there are some tests available, they have different degrees of sensitivity and specificity in different populations, and they don't yield particularly reliable results in children and in HIV-infected people. So in Mike Levine's group at Imperial, and I know other people are working on this as well, we've been working on a paradigm shift. So instead of looking for the pathogen that may be lying in sites that are not accessible or in numbers that are not detectable, we're looking at patterns of gene expression in whole blood and patterns that are specific enough to allow for distinguishing between different diseases. And the way we do that is we take 2.5 ml of blood and we put them in PAX-gene tubes. We purify RNA, we check for quality, and then by using a hypothesis-free manner, we measure 31,000 transcripts on a microarray. And there are different technologies to do it now. People have been starting using RNA sequencing, but I'm going to talk today about microarrays. And the TB field has been following this up since 2007. And there are many studies out there. I'm not expecting you to be able to read all these, but I'm just going to highlight that fairly recently, in 2014, people have started looking at pediatric TB in terms of whole blood gene expression. And I hope next time I'll be able to squeeze a few more in there. So today, I'll focus on our study, the ILULU study. A consortium came together in 2006 with a big vision of identifying a gene expression biomarker set that would be able to distinguish active TB from other diseases that clinically mimic TB irrespective of age and HIV status. And the adult data were published in 2013, and today I'm going to focus on the pediatric data. So a little bit about the study design. The clinical teams recruited patients in 3 high-incident rate countries in South Africa, Malawi, and Kenya. And we used the patients from South Africa and Malawi to discover our signatures, and then we applied them on a completely independent validation data set that we kept aside from the beginning in Kenya. And we only used the gold standard TB cases and other diseases, so we only used culture-confirmed patients to come up with the signatures of disease. And we, by using bioinformatics analysis and played with numbers a lot, we managed to identify genes that are switched on in TB and switched off in TB. And we combined them in a patient disease risk score that reflects the probability of a patient having TB. And then we evaluated them in independent validation cohorts. So when we first looked at the genes, we saw a very big number of those 30,000 genes being differentially expressed between TB and other diseases. And then by using variable selection techniques like elastic net, which acts like a fishing net and only retains the big fish, we managed to identify 51 transcripts that could act as biomarkers between TB and other diseases. And when we applied the signature to our validation cohort, we saw a very good separation between our cases and our controls, with an area under the curve of almost 90% and good enough sensitivity and specificity around 83–84%. And we also compared the results with the results that expert yield, and we saw that we had a better area under the curve, we had better sensitivity, but expert was much more specific. And when I was asked today to talk about analytical challenges, I didn't struggle to find two of them to talk today. So first, I'll focus on the indeterminates and how we deal with those. So as you all know, bacteriological confirmation is the exception rather than the rule in childhood TB. And out of children that have probable TB, around 70% of them have negative cultures. And treatment is quite often initiated on clinical judgment and exposure history, clinical features, and chest X-rays. And the number of true TB cases among culture-negative TB patients remains unknown. So in our clinical categorization, we had confirmed tuberculosis, other diseases, and we also had this group of culture-negative TB. And we assigned them in 3 different groups according to the clinical team's assurance of the patient having TB. So we had a highly probable TB group, a probable group, and a possible group. And when we applied our signature to those groups, we saw a really nice gradient that matched the clinical prediction of the patients having TB. But then we struggled quite a lot to identify the right way to calculate sensitivity in those groups, because each of those categories is not really culture, it's not really TB. So in each of those categories, we have a mixture of actual TB cases and other disease cases that can be clinically confused with TB. So we came up with a way of dealing with this. We call it the effective sensitivity. And I'm not going to go into much detail about it, but we investigated a range of different prevalences at rates of actual TB, of true TB on those groups. And then we calculated those areas under the curve that after the adjustment for effective sensitivity, they look pretty similar. The next analytical challenge I'm going to touch a little bit on today is how to make those gene signatures even smaller. So it's okay to have 51 transcripts, but it's not ideal if you go to a diagnostics company, they probably want to measure even less. So when we looked further in our signature, we saw that our genes are capturing more or less the same information. So you can see those big blocks of highly correlated genes there. They're contributing probably the same pathway for the patient to fight off the infection. So we thought, can we remove those highly correlated genes and reduce the size of a signature even more? And we came up with this method that's called forward selection partial least squares method. And it's an even better fishing technique, so it really retains only the really big fish. And by using the same analysis pipeline, we discovered on our South Africa and Kenyan cohort, South Africa and Malawi cohort, and then we tested on the Kenyan cohort, we came up with 3 genes. And as you can see, they're not as highly correlated as this big block here. And we tested the signature, this 3-gene signature, in our test data set. We had a very good area under the curve of 92%, a good sensitivity and specificity. And then we also tested in our validation cohort that we set aside from the beginning. And we didn't have such good specificity, but we're still fixing the threshold. So it's a work in progress. And the last remark I want to make before I close my presentation is that we probably need a pediatric-specific signature, and our work and the Sweeney work published this year in Lancet Respiratory Medicine has shown that you cannot really use adult samples to come up with signatures that work in children. And as you can see here, they presented a 3-gene signature that works very well in adults, but not as good in children. Sorry. And we've been working with clever bioengineering people to make that work into a point-of-care diagnostic test. And we recently published on nanoscale that we can identify the quantity of multiple transcripts at the same time from our samples, which is quite exciting and probably paves the way for a point-of-care diagnostic test based on transcriptomics. So I want to conclude by saying that we have small biomarker signatures from whole blood that distinguish TB from other diseases in children, that we really hope they will form the basis of a diagnostic test in the future. There are many analytical problems yet to be identified first and then solved, but we really feel that this transcriptomic medicine research field can change tomorrow's medical practice, particularly in areas that it's most needed. And I'd like to thank a lot of people that have been working around the globe on these questions, particularly Brian Ely, Suzanne Anderson, Robert Heiderman, and Andrew Brent that led the clinical recruitment in sub-Saharan Africa, Victoria Wright and Lachlan Coyne, and of course Mike Levine, who's been the PI of the project and the driving force behind it. And thank you all for listening.
Thank you very much, Massini. Have we got any questions on that? We've got a few minutes. Yes, Andrew. Can we have the microphone?
Hi, thank you so much for a fascinating presentation. It's great to look at sort of host immune response rather than pathogen detection for TB in kids specifically. My question to you is, when you looked at using the partial least squared, which I don't claim to understand in any way, shape, or form, the 3 genes that you identified that looked like they were downregulated, what gene classes were those?
So one of them was GPP6, if I'm allowed to say. We had one that was identical to the Sweeney signature, DASP3. And the third one, it can be one of 3 genes, so we haven't identified which one of the 3 we're going to use further on. But yeah, so common suspects.
But I think that having the genes which best discriminate disease states may be very different to understanding what they do biologically in immunology. They're 2 completely separate fields in a way. A question I'll have for you, Massini. So, I mean, in that middle group, the probable group, there is probably some kids genuine with TB and some that don't have TB, and that muddies the waters, perhaps. Surely we need to do a study where we just rely on this and just treat children who have this signature and very, very intensely follow up children we're not treating and see what happens.
Yeah, totally. So the way forward is clinical trials based on.
But I mean, I don't know which ethics committee is going to be following
that. I don't think it's going to be anytime soon, but that's the only way to find out if your test works.
I think that's true. Any other questions on this? Thoughts, comments?
Okay.
Thank you very much,
Thank
Massini.
So next we have Rebecca Harris, who's based at the London School in the TB modelling group, and is, among other things, doing her PhD, talking about the potential impact of BCG shortages on child mortality from TB.
Thank you very much, Pete. So many of you will be aware of the sizable shortfalls in the supply of BCG vaccine that have occurred over the last few years. And these shortfalls are sizable enough that they've led to countries experiencing shortfalls, leading to missed vaccinations at the local level. Now, obviously, this is a manufacturing problem. It's a manufacturing and it's a supply problem. But in the end, it's going to be a public health outcome that's going to be the problem. And there'll be additional TB cases, there'll be additional TB deaths, due to babies not being vaccinated at the country level. So this is where quantitative methods come in. So we can use quantitative methods to estimate the public health outcome of such shortages. So what I'd like to share with you today is the results of some work we've been doing to estimate the potential impact of BCG vaccine shortfalls on childhood TB mortality. So if I can, I'll just take a moment to highlight why BCG vaccination is important. BCG is a cornerstone of the childhood vaccination. It's been used for more than 42 years as part of the EPI schedule. It's a safe and it's an effective vaccine, and it's provided to over 100 million neonates annually. So given it's such an essential part of TB control of our vaccine programs, how is it that BCG shortfalls have occurred over the last few years? So supply comes from two groups of suppliers. There's the pre-qualified suppliers and the non-pre-qualified suppliers that can supply to non-UNICEF countries. And what happened in 2014 was 2 of the 4 pre-qualified suppliers experienced technical difficulties, leading to reduced supply. There was also one supplier that had planned engineering works conducted, and so they were anticipating to have reduced supply. In addition, several of the non-pre-qualified manufacturers left the BCG market. So we can compensate for small-scale changes in BCG supply, but clearly the market is relatively unresponsive to either rapid or large changes in supply or demand for BCG. So given the lack of responsiveness, we ended up with shortfalls peaking at 22.8 million doses in 2014, and this continued on through into 2015, where at the end of 2015 there was still 16.5 million dose shortage globally. So clearly current measures to ensure BCG supply continuity are insufficient. So it's important to understand the public health impact of such shortfalls in the short term to act as a driver for rapid corrective action when they occur, and in the slightly longer term to advocate for measures that will protect the BCG supply chain. So in the shorter term decision making, epidemiological data won't be available to be able to inform that, and so what we need is mathematical modelling to be able to make estimates of these public health impacts. So using data that was available from TRUNS, it's possible to approximate the number of additional cases that may occur, but there were no existing estimates of the number of TB deaths that are currently averted by vaccination levels, and therefore the mortality impact from shortages. So this became an urgent modelling question during these shortfalls. So we had 2 research questions here. The first is how many paediatric deaths are currently being avoided by routine BCG vaccination globally? And the second one being how many additional deaths might be expected per cohort affected by these recent shortfalls. So the approach we took was to develop a static mathematical model to be able to estimate the number of deaths avoided in the first 15 years of life by usual vaccination coverage. Now we took as a baseline 2013, as that was before the shortfalls really started occurring, and usually 240 million doses are supplied to give 90% coverage in that year. We also wanted to estimate the number of additional deaths in the first 15 years of life per cohort affected due to these supply shortages. So at the end of 2015, 16.5 million doses were estimated, but actually earlier in 2015, it had been anticipated there would actually be a 71.8 million supply shortfall, but due to mitigation measures, they managed to avoid the majority of this and ended up with only 16.5 million, so we can estimate the number of deaths averted by those mitigation measures. So just to start with a few of the parameters and the assumptions that were built into the model that we developed. So we developed a global level model, not a country level, but a global level model based on the available data. We estimated the size of the global birth cohort and assumed that vaccine would just be delivered to those HIV negative since it's contraindicated in HIV positive children. Now, one of the key parameters, input parameters into the model was the WHO TB mortality estimates, which obviously, as Helen has already discussed this morning, these numbers have changed recently, and I will come back to this later as to how the recent update in TB pediatric mortality estimates do affect the results that we're presenting here. But the results I'll present to start with are from the 2014 report, the 80,000 pediatric TB, HIV negative pediatric TB deaths that were estimated in 2013. So in terms of vaccine deployment, usually there are 260 million doses supplied each year, and this in 2013 led to a 90% coverage of neonates. And then finally, in terms of vaccine characteristics, we assumed 15-year duration of protection, and from the Abubakar study from 2013, the vaccine efficacy of BCG against TB mortality was estimated at 66% with a range of 8 to 88%. We assumed there was no waning of protection, and we also didn't assume that there are any catch-up campaigns. So just to briefly go through the modelling methods that we used. So firstly, we needed to estimate the number of unprotected children in the birth cohort. So if this is the birth cohort, first you estimate the number of children who didn't receive the vaccine, and then of those who did receive the vaccine, based on the vaccine efficacy, the number of children who will have been unprotected by the vaccine. And so this gives you the number of unprotected children in your birth cohort. Oops, it's gone too far. We then use this and the TB estimates of pediatric mortality to be able to estimate the individual level risk of TB death in the first 15 years of life. And then we start looking at the shortfall scenarios that I mentioned. And so for each of those, we calculate the coverage and then calculate the number of unprotected in each of these shortfall scenarios, as I already described for that baseline scenario. And then what we do is we use this calculated risk applied to each of those shortfall scenarios to estimate the number of additional TB deaths occurring in each of those scenarios. And of course, it's important to take account of the uncertainty in the input parameters in the model. And so we accounted for uncertainty in the mortality estimates and also the vaccine efficacy against TB death by taking 100,000 randomly selected parameter sets from log normal distributions of both of these parameters to be able to estimate the median and 95% uncertainty ranges for the outcomes of interest. So as I said, our first research question was to estimate the number of TB deaths, HIV-negative TB deaths that BCG averts each year. And so from our model, we estimated that around 117 TB deaths would be averted in the first 15 years of life of one cohort vaccinated at usual levels of coverage, which, as I said, was 90%. With an uncertainty range, of 5,000 to around 300,000. And that uncertainty comes from our uncertainty in the vaccine efficacy estimates coming from that meta-analysis. Now, if we were to think about what the world would look like if we didn't have BCG, so the baseline estimate of paediatric TB mortality was 80,000. If we were to have no BCG available, the modelling results suggest that we'd have almost 200,000 deaths. Now, if we then think about the impact of recent shortfalls, as I said, in 2015, a 16.5 million dose shortfall was estimated at the close of 2015, and we estimated that this would be associated with 7,500 excess TB deaths in that birth cohort in the first 15 years of life. Now, just to note here, this is just a one-year shortfall, and as I already mentioned, those shortfalls went on for at least 2 years, and so this is just for 1 year, so the number of additional deaths would actually be greater than this given the shortfalls we experienced. And then also, what's really important to note, though, is that the mitigation measures that were put in place to reduce those shortfalls in 2015 potentially avoided 25,000 paediatric deaths over that period, with a range of 1,000 up to 65,000. So obviously, all models are a simplification of reality, and I'll just go through a few of the limitations of the approach that we used here. So firstly, we used a static cohort model, which does assume no transmission. We assumed that there was no waning of protection and no catch-up campaign. So obviously this means that we'll have slightly overestimated the impact of shortfalls. But also we don't account for the non-specific effects of TB vaccines, which have been indicated by more recent publications. And so potentially we're actually also underestimating the impact, given that there may be non-specific effects on mortality. There is a need for better data. So the vaccine efficacy against mortality, as I said, there are only 5 studies that inform that meta-analysis with only a few endpoints, mortality endpoints in there. So the confidence intervals on that were very wide. So there is a need for maybe prospective cohort studies to inform better vaccine efficacy against mortality estimates. Now, obviously, countries have buffers available, and therefore shortages don't necessarily directly lead to local level stockouts. However, WHO reporting from 2014 indicated that at least 6 of the 22 high-burden countries did experience local-level stockouts that led to children missing vaccination. There is a geographical heterogeneity in the shortfalls and the burden of disease. Now, here we developed a global-level model because actually there's only the TB paediatric mortality estimates at the moment are only available at the global level. Now, obviously, we're hoping within the next year or so to have country-level estimates, but with the data that was available, only a global-level estimate was possible. But I think a country-level model could be important to tease out some of the geographical heterogeneity that could have occurred. And as I already mentioned, we only estimated 1 year of shortfall here, but if there are multiple years of shortfalls, obviously a greater impact would be expected. And coming back to the fact that the estimates for paediatric TB mortality are changing, the methodology is evolving. And so just to come back to, as I mentioned, that the fact that WHO have updated their estimates. So the estimates have increased from 81,000 up to 169,000 HIV paediatric TB deaths in 2015. So if we estimate back, there's been a 2.7% decrease in mortality overall. And so we estimated back to 2013. Then 2013, there was likely around 179,000 paediatric TB deaths based on these new estimates. So we looked at what our results would have been if we'd have used these new estimates. And so say, for example, so the green is our original estimates and the blue are the updated estimates. So you can see there'd be a big increase in the estimated additional deaths. And actually, so say, for example, with the 2015 6.3% BCG shortfall, our estimate of around 7,500 additional deaths would actually increase to 16,500. And so just to conclude, the recent shortfalls demonstrate that the BCG supply chain is relatively unresponsive to either rapid or large changes in supply or demand. But given that BCG is a mainstay of neonatal vaccination, therefore even relatively small shortfalls could actually lead to a substantial number of additional paediatric deaths in the affected cohorts. And the public health risks of larger or longer shortfalls are considerable. With evolving methods for estimating paediatric mortality, these impact estimates can be revised and are likely to, as I said, go up. There are significant policy impacts of this. It is a current issue of global relevance. There are no new manufacturers intending on entering the market. If anything, manufacturers seem to be leaving the market. And there are no current plans to upgrade facilities to be able to increase production at existing producers. So the development of a secure and a responsive mechanism of supply to adequately meet global demand should be a global public health priority. And this could include measures such as reducing vial size to reduce wastage, because actually wastage of BCG is around 50%. More efficient manufacturing techniques such as liquid fermentation, and also potentially political or financial drivers to help incentivize manufacturers to either enter or stay in the BCG production market. So what remains is for me to thank my co-authors, Pete Dodd and Richard White, the many contributors from LSHTM, the Bill and Melinda Gates Foundation, UNICEF and ARES who contributed to this work, my funder, the UK Medical Research Council, and finally, thank you to you for listening. And just to note, this work has been published recently, so it can be found online. So thank you very much for your attention. I'm very happy to take questions if I haven't run over.
Great, thanks very much. We've got time for a few questions, if there are any.
Can I start off by just asking a quick one? Sorry, Tom. Just very quick.
Yep.
I mean, immortality is clearly important, but
Yes.
one of the big things the vaccine does is protect children from TB meningitis, which you've heard this morning is how devastating. Were you able to in any way quantify the increased number of cases of TB meningitis in children? Is that something that you didn't look at or thinking of looking at? Or?
Yeah, so that's a good question. So that wasn't something that we were aiming to do here, because using the data from TRUNS, you could do a back-of-the-envelope calculation, because, so I think for TB meningitis, you get one case averted per around 3,500 vaccinations. And so you can take the number of vaccinations that the shortfall, apply the wastage, and then you can calculate. Some back-of-the-envelope calculations were done to calculate, I don't have the numbers off the top of my head, but were done to calculate the additional number of severe cases.
Is it more than the deaths, or is it sort of...
Yes.
So of the sort of 100,000 deaths that we're protecting each year, we're protecting even more cases of TB meningitis by giving the BCG currently?
That's what you would estimate from those numbers, yeah.
Sorry, Tom.
Hi, Tom.
Are there consequences to this big stuff up? You know, it's terrible. What are the consequences? Are there legal consequences?
No, so I mean, there are no legal consequences to it, because obviously a manufacturer has the right to decide to stay in the market or not. And so that's why I mentioned maybe kind of either political or financial incentives to try and keep manufacturers in the market. And one of the main concerns, I think, from manufacturers at the moment is because there is this strong vaccine pipeline coming through, potentially with BCG replacement vaccines, that manufacturers are concerned that manufacturers are thinking over a 20, 30-year timescale, so they're concerned that BCG won't be required. And but I think the important thing is to communicate to manufacturers that BCG, the likelihood is that with many of the candidates coming through, they will be given as a booster to BCG, so it is important and BCG will still be needed. But as far as I'm aware, there are currently no legal consequences. But WHO has made efforts to bring on more manufacturers as pre-qualified manufacturers. So if they have as many problems as occurred recently with pre-qualified manufacturers, that they can still get access to pre-qualified vaccines to be able to provide to those low and middle income countries.
Okay, any more questions? Excellent.
Thank you very much.
Thank you very much. And at the last minute, Anna arrives, leaping in. So can I introduce Anna Mandelikas, who is working at Baylor and is going to be telling us about health economic modelling.
Thanks, James. It's a pleasure to be here this morning to share with you some of the work that we've done on modeling the cost-effectiveness of household contact tracing in children. So I have nothing to disclose. And so I aim to give you an overview of IPT efficacy and examine cost-effectiveness of child TB contact screening strategies by exploring the application of cost-effectiveness modeling in child TB. And since I only have 12 minutes here, we won't talk about any other regimens. We won't talk about how good IPT prevents TB in guinea pigs. But kind of the most important thing to consider for the modeling is that IPT is actually very effective in children. And there's a lot of evidence to support that statement. This is one of my actually favorite studies, even though it's an observational study, but it was work done by Catherine Hugh in Houston, actually, where she describes 30 years of observations in children she treated. So 2,500 children who all completed preventive therapy. It's 16,000 patient years of observation, and the children ranged from birth to 15 years. She followed them for up to 23 years, and she actually showed that only 8 children developed disease, and that IPT was most effective in children less than 4 years of age. None of them developed overt disease. So we fast forward to the most recent data on IPT in children, which is a systematic review of 8 RCTs comparing IPT versus placebo in over 10,000 children. The cohort had mixed exposure and infection risk, and it was a very heterogeneous population with respect to factors that might moderate the efficacy of IPT, such as age, HIV status, TB endemicity of the setting. And the studies also heterogeneously used IPT with respect to dosing and also the type of prophylaxis. So in addition to showing that INH hepatotoxicity was qualitatively minimal, the most important thing that the study showed was that among children between the age of 4 months and 15 years, IPT reduced the risk of TB progression by 59%. So we look at the 8 studies in this meta-analysis. 6 of them the authors deemed as high-quality studies. The first 3 studies were exclusively in HIV-infected children. The first 2 studies, the MADI studies, were actually included HIV-infected children less than 4 months of age who had no TB exposure. So therefore, giving them isoniazid was preventing infection, primary prophylaxis. Of the remaining 6 studies, 2 were secondary prophylaxis because they included only children with a positive TST, so therefore they were preventing progression to disease. So we look at the summary statistics from this meta-analysis. You can actually see there's a lot of heterogeneity, and they went on and still did the meta-analysis. And then we also see that they report a summary statistic with a relative risk of 0.65. But if we actually look more closely and divide the studies by primary and secondary prophylaxis, the studies with primary prophylaxis contribute more than 50% of the weight in the model and really drive that summary statistic. And if you look at the other studies, which are not the infant studies, we actually have this risk ratio of 0.41, which is much nicer. Actually, it's really important to look at this because this collection of studies is what drives IPT policy and why the guidelines that we have about who we use IPT in children sometimes seem a little funny to us. But it's really from these collection of studies. So in summary, from the other thing that the weighting, the differential weights of the infants did was it actually makes it difficult to draw conclusions on all-cause mortality, the HIV status, and the TB endemicity. So actually, just to highlight this a little bit, the HIV piece, which is what really drives the policy, in the HIV negatives, we have this relative risk of 0.55, and the positives 0.86. But then if you remove those MADI infant studies with primary prophylaxis, you're only left with the Heathers-R study, but your risk ratio is 0.28. So this is what's driving policy for IPT in children. So in conclusion from this meta-analysis, we actually really can see that IPT is effective in children, but particularly children at risk of TB, children who have contact. But we need more evidence on IPT use in young HIV-infected children and actually the optimal length of treatment. Okay, the second really important thing to note as we go into this model is that INASE toxicity is really rare in children. There's a ton of evidence to support that statement, and our team reviewed this a lot to talk about estimates to use in the model. So we go all the way back to some very old observational data from the 50s, 60s, 70s, shows most of the side effects are GI symptoms like vomiting and diarrhea. More recent quantitative studies. This is one of my favorite studies that actually looked at all US liver transplant centers over 7 years, and it showed that the probability of non-fatal hepatitis in children on IPT was 0.003. All right, so when we think about risk-benefit ratio of IPT and put this into a model, it's very effective and it has very little hepatotoxicity. All right, so I'm going to tell you a little bit about the model that we developed to actually look at strategies to prevent tuberculosis in child contexts in a high-burden setting. And there's very limited IPT cost-effectiveness data employing pediatric-specific estimates, probabilities, and costing. So we started out, so I'm going to give you a broad look at the model, and then we're going to hone in on different pieces of it. So we used a decision analytic model and a Markov modeling piece. So you start out with your population here at the left, and you change your population depending on what your question is that you're answering. Everybody goes through this initial decision mode, and in our model, the decision mode had to do with what the screening strategy would be. After you go down a different branch for screening strategy, if you have a testing strategy, you go through chance nodes about how that test performs. And then everybody goes on to these chance nodes that has to do with whether you get referred for IPT, you initiate, you take your IPT. And then at the far right, you enter this Markov model, which transitions children through these health states, so you can actually measure your outcome at the end. So we used a population of 10,000 simulated child contacts without TB and without HIV. And we actually used two populations. We used children less than or equal to 2 years of age, and then another cohort that was 3 to 5 years of age, because the risk of disease progression is different in those two age groups. So as you travel through those Markov models, you need to use different probability estimates. We had 5 testing strategies. We had a no testing strategy, which basically means everybody who entered the model was eligible for IPT because they were household contact, under 5, and they didn't have TB. The testing strategies were simply TST, agar alone, agar after a positive TST, which maximizes specificity, or agar after a negative TST, which maximizes sensitivity. And then the IPT chance nodes actually looked at referral uptake adherence, and we actually, based on our study setting at that time, we actually used very low IPT usage. All right, so this is the Markov model. We had 7 health states. So no infection, initial infection, future infection, pulmonary TB, disseminated TB, TB death, yes, that's a health state, TB death. You can laugh. And then death from other causes. And as I said, we adjusted the transitional probabilities based on their age. We also modeled a setting with a high annual risk of an infection. And we ran the model for 15 years at 6-month cycles. So kids had a lot of chance of getting reinfected. But we only offered IPT once during the course of the cycle, and we actually made an assumption out of a lot of debating, I'm looking at Simone and laughing, that IPT only provided protective efficacy while you were swallowing the tablets. There's just not enough data out there to say it lasts longer, and we just all concluded after a lot of discussion, this was it. So basically, if you want to take all of that, and it's in the red there, our model evaluates the impact of offering one course of IPT to children who survived the perinatal period, had household TB exposure, did not get TB, they were identified through a contact tracing program, and they had a lot of chance of getting infected again over 15 years. Okay, so you want to know what the cost effectiveness is, but we can't do that yet because we have to think about the assumptions in the model. So, right, this is unique context to South Africa. that employs estimates of test performance that were for active TB that are not the perfect estimates of test performance. We still don't have good estimates of these test performance because we don't have a good reference standard for infection. Other assumptions were in the costing, 2 visits for everything, additional cost for a lab visit if you had an IGRA done. Everybody got chest x-rays. The IGRAs were batched with decreased cost. And this is key, contact placing was in place already. So it should be happening, and that cost isn't put into the model. Adverse events from INH are negligible, and this was another big debated point. We said that TB infection was not cleared, so that once you were infected, you couldn't progress to a non-infected state in your Markov models. All right, so now I'll tell you about the cost effectiveness. So this column is the cost effectiveness measure for our model. We looked at cost per life year saved. Okay, we had 2 base case scenarios. The first base case scenario is 0 to 2-year-old cohort, and then we looked at it with quantiferon being the test or T-spot being the test. What this actually showed us, as you can see, is the no testing strategy dominated in children less than 2 years of age. So it's cheaper, it's more effective in children less than 2 years of age in this setting. So then these are the other base case scenario, which is 3 to 5-year-olds with quantiferon as your test, or 3 to 5-year-olds with T-spot as your test. Actually, what we actually saw, what I say here, is that no testing is the preferred strategy in this 3 to 5-year-old group. The reason it's the preferred strategy is actually this strategy, agar after negative TST, is actually more effective, but it's very costly. And so we talk about incremental cost effectiveness ratios now. So in this scenario, the incremental cost effectiveness ratio is the additional cost per additional life year saved. And it's like $250,000 for each additional life year saved, which is a lot of money even in the US as I look at Andrea's face. Okay, so we did sensitivity analysis looking at LTBI rates and test performance, ranged them broadly, and it didn't change anything in the model. So kind of boiling this all down, I could stop right here. I don't know where my time is. Am I supposed to stop right here? So we could say IPT is cheap and safe in children, you all agree, but if we look at the numbers, the cost per life year saved range from $140 to $538. It's just cheap. So again, I could stop here, but that's me saying it's cheap. What's the definition of cheap? So the WHO has their committee on macroeconomics that says cost effective is if an intervention is less than 3 times the GDP. So at that time, the GDP in South Africa was $5,700. We are way below the 3 GDP just threshold. And then if you still don't like this stuff because it's too far out of your realm of practice, we can look at the cost of treatment. So if we treat a child with IPT at that time, it was $119. This is the societal cost. So it's the cost of the families, time, all of this kind of stuff. It's the appropriate perspective. And you look at the cost of pulmonary, miliary, TB, TBM, disseminated TB. A case of TBM costs $30,000 in a child. And so even if you're not altruistic and worried about children dying and getting sick, very pragmatically speaking, IPT is cheap, it works. All right, so the other things to consider here, and it's so exciting to be at this meeting and see all the momentum about IPT, is that everything in the beginning of the decision tree has to do with policy, right? Like, what are you going to do to screen these kids? Are you going to find them? Are you going to refer them for treatment? Are you going to provide IPT for them? And then next comes uptake, and next comes adherence. All of these things actually are the very beginning of the model, and they completely affect your outcomes, right? These are all things we can all address in our practice. And I love this study from Dick Menzies' group at McGill, which actually looks at the bottom line on cost effectiveness, and they actually looked at close contact screening. And what they actually showed from this study is great. All screening strategies would be much more cost effective if a higher proportion of those with a positive screen actually completed medical evaluation and took their TB infection treatment. So basically, by improving program performance, you can actually quadruple the public health impact of your program and halve the cost per case. All right, so I just want to acknowledge many, many partners from lots of different places who put a lot of energy into debating all these estimates for the model. And then encourage all of you to step up and join the campaign. And want to point out that we are also including in this campaign screening contacts and preventive therapy.
Thank you very much, Anna. Excellent. Any questions on that? I'm sure there are lots of questions.
I've got sort of obvious one. I mean, it struck me that some of the assumptions you're making for the South African context, well, in the model, but also around the South African context, were quite conservative in terms of impact and how you're doing. I was just curious about generalizability to other contexts and whether you thought about which factors most influence this. Generalizability to other settings and the factors which most influence that.
The findings and the settings which are most
Generalizable. Which factors are most important if you're going to generalize to other contexts?
Okay. I mean, my biggest point here is that it's actually very cost effective. And I mean, just any of those strategies work. I'm sorry. So obviously it's very cost effective and any of the strategies work. I mean, the no screening strategy, which is what we're recommending in high burden settings, no testing strategy, works very well. It's very cheap. But, you know, we can also use a test if we want to, but it's very costly. That's the most important point. I think that's generalizable across probably all settings.
Yeah.
No, yes.
Hey, Anna. Further on that point, I mean, in terms of convincing programs to actually implement screening, obviously the cost effectiveness argument is really important, but I think presumably that would change once you did include the costs associated with contact tracing in the first place. So is that something that you looked at from a program perspective or something that you will look at, the total cost of implementing these programs in endemic settings?
I can try. No, it's fine. It's really just, I think the question was about if you included all the costs to the program, including the household contact tracing, how does that fit in? Is that a fair assumption?
It would be a much more complicated model. And there's been one study in the interim looking at adults that's actually included costing of the programs. And actually the other thing that it looked at, which helps the cost effectiveness, is reduction of secondary transmission, right? So we didn't do that in this model at all. Obviously, the costing of a contact tracing program is going to make this much more expensive. And so it's something that the public health perspective obviously would be much more interested in including as they do program planning.
And
but it's definitely a limitation of this model. There were so many variables in this model that we wanted to explore that were unique to pediatrics that we actually discussed a lot and chose not to include the costs of the public health program. Besides, the cost of the public health program would make the model even less generalizable to other settings because the cost of contact tracing varies so much from one country to another, so we actually chose not to include it. I think that really interesting thing would actually is the models that look at decreasing secondary transmission, because that would make all of this even more cost effective. But again, that dynamic model is much more complicated.
Any other questions from anyone? Any questions from anyone about any of the 5 talks we've had? Because we've got a few minutes to talk about any kind of questions they've got to do with quantitative approaches in childhood TB. So we can quiz any of the speakers if you've got any burning questions.
Oh, it's on. Marilla Gennaro, Rutgers University, US. It's the first speaker, which I think is you, right? I may have missed something, but I think you said, you know, the 1 million deaths, and then, sorry, the 1 million incidents, and then when you talked about mortality, you had two numbers. One was a 1%, that was during the mortality, the 1% mortality, and then you had 200,000 deaths, and I couldn't put the two things together.
So we actually broke the 1 million down into children who did receive treatment and children who didn't receive treatment. So the 1% applied, broadly speaking, to the children that did receive treatment. But we believe that about 2/3 of incident pediatric TB cases don't receive treatment. And those estimates we had for mortality in those children were about 22%. Okay.
Any other questions or clarifications? Well, if there's nothing else there, we might finish a few minutes early so you have time to get your next sessions. But thank you very much. I think it's been I've really enjoyed the session, thinking about different ways of thinking and using data to better understand how to diagnose children with TB, better understand the impact of vaccines, better understand the burden, think about the use of IPT and the cost effectiveness. And I think that generally we've had a very good session. So I'd like to thank all the speakers and thank you all very much for attending.